Welcome, everyone, to the LACNETS meeting. This is our October meeting, and we're so happy to see everybody here. I'm Giovanna Imbesi, and this is Lindsay Giovanna, our events coordinator for LACNETS, who you know from last month. And I want to really give Lindsay a big thanks for running the meeting last month. She did an incredible job, so let's give her a hand. I have a few announcements, and then we'll get started with Tina. One is that Dr. Coons at Stanford let me know that they have just opened their PRRT EAP program. So what is that? That's the Expanded Access Program. It's the preliminary time in between the trial and the actual approval, which is set for December 28th by the FDA. And it's a program that's running here at UCLA, UCSF. Stanford just opened. So these are very few slots. They're for the carcinoid patients, and it's completely covered. The costs are completely covered for PRT. It's a series of 4 treatments over every 8 weeks. So if any of you are considering that, you can talk with your doctor. We just want to let people know that this is now available at Stanford. Speaking of PRRT, our next meeting will be on PRRT. It's going to be November 10th. We're going to move to a Thursday just for that month because it's NET Cancer Day. And NET Cancer Day is a worldwide celebration of neuroendocrine tumor cancer patients. So I hope you'll join us. We're going to be at a special venue. It's the Tower Cancer Research Foundation, which is right down the street here in Beverly Hills. They have a phenomenal facility. It's worth visiting just because it's gorgeous. There's free parking that's really easy, just a few steps from the elevator. And so the meeting is going to be on PRRT, the patient perspective. And we're going to have a few patients, between 3 and 5 patients, talking about PRRT from the patient perspective, sharing experiences. And in the next few weeks, we'll be announcing who the patients are. I know I'll be one of them. And Josh Mailman is actually going to be, who leads the Northern California support group, is going to be in Australia at a conference, but he's going to Skype in. And hopefully he's going to Skype in with Dr. Baum from Bad Berka in Germany. So look for if you're not already on our newsletter, let us know. We'll add you to that. So that's going to be a great meeting, and I hope you'll join us on November 10th to also celebrate NET Cancer Day. By the way, their calendars are in the back, Tower Cancer Research Foundation. I just had an oncological massage. They have these incredible programs there, and it's all free. So massage, Reiki, they have all kinds of things in their calendars in the back, and it's everything's validated. It's a really great place to visit, so I encourage you to check them out. Next week, I'm flying back to New York for a very special roundtable on carcinoid syndrome that is going to be with many neuroendocrine tumor experts. Dr. Wolin will be there, Dr. Bergsland from UCSF, Dr. Liu, the 3 W's, Warner, Woltering, and Warner, will all be there, and I'll be one of the patient advocates to learn more about carcinoid syndrome and what's coming early 2017 for that. When I was in Germany, I spoke with Dr. Hort, who does the ultrasounds there, and he said they've been having tremendous success with telotrestat, which is a new drug we expect to have approved in 2017 for people with carcinoid syndrome. So this is really going to be a game changer for people who have syndrome and suffer from some of those side effects. And last but not least, this Saturday, October 15th, we've had the speaker from Triage Cancer Inc., Joanna Morales, speak to our group, and they are doing a special work and cancer event this October 15th, and it's all free. They're going to be speaking about disability insurance, any kind of financial legal issues. So there's some flyers in the back, and the registration is open. It's at downtown LA. So, so I want to welcome Tina Ban, our speaker today. Many of you know Tina very well.
Hey y'all, how are you? Great. I know most of you, well, about 75% of the folks in here. I'll give a little more background for me. I've been an oncology nurse 25 years. The last 5 years I've been here and have fell in love with neuroendocrine cancer. Dr. Wolin, who was the former head of the Carcinoid Neuroendocrine Program here, he's now in New York, kind of turned me on to it. It's very fascinating, but it can be very confusing. I have been in one of my former roles, the patient and family educator for the oncology division at Northwestern Memorial Hospital in Chicago. So I've taught managing side effects before. Basically what I'm doing is I'm tweaking it a little bit for you guys. You guys, I apologize in advance for those of you that have sat in the room with me and watched me fight with the computers here at Cedars. Technology and I have a love-hate relationship. It hates me right now, so we have no PowerPoint, okay, which is why we're sitting in this format. I do have a couple of rules when I teach. Number one, no phones. Number two, no notes. Okay, everything I am going over, I have in a handout right here for you. You learn best by sitting here and listening and interacting with us together, okay? You don't need to take notes because number one, it's right here. Number two, it's gonna be filmed. So if you miss something or you think I didn't cover something or I forgot to put something in the handout, which I am sure, as thorough as all of you guys are, y'all are gonna make sure I know about it when you come in for your next injection appointment. Y'all always tell me. You'll be able to log onto the LACNETS site and pull up the video and have everything there, okay? So you've got it two places. You're not gonna miss anything. Right now, I just want you to relax and listen and let's discuss some of the things that are going on. They have informed me I can't be personal right now when we are going over this. I can't call you by name. So if I just point to you or whatever, we're going to try to save some of the bigger questions and things like that to the end of the presentation for the round table. I'm going to be asking a couple questions and I want you to just raise your hand if you know the answer or something like that. If you have a question and we didn't get to it, I have index cards and pencils. I'm sure y'all have a pen. That's the only time I want to see y'all writing, okay? You can put it on the card. You make sure I get it. If you're not a Cedars patient and I don't know you, please put your phone number, your email, or whatever. If I don't know the answer, I don't have time to answer it because we got a lot of information to cover in a very little bit of time to do it. This is actually a class that could probably be broken up into 4 separate hours and things, but I'm trying to hit the highlights right now. I'm not going to be covering every side effect that affects every one of y'all, all right? So put your question on there. I'll let everybody take a card or two and pass it around. We'll start the handouts this way. Rowena, our nursing assistant in the back. Yay, Rowena. Most of y'all know her. If we don't have enough handouts right now, she's going to find out how many more we need, and she's going to go run and make copies and make sure everybody in here has a copy. Okay, because we don't want anybody to go home and feel like they don't have the information that they need. Any questions so far? All righty, awesome. Let's start. I sit down a lot. Most of you know I do have fibromyalgia, and so I get tired easy, and I'm going to be try to put out a lot of energy for you guys. So I may be up, I may be down, but right now I'm going to sit down for a few minutes just while we get started, okay? All right. All right. First question for everybody. Can name me, who knows what are some of the treatments for carcinoid neuroendocrine cancer? Okay. I need to hear more. Come on, wake up. All right, we got sandostatin, we have lanreotide. What else? Chemo. Okay, what types of chemo? Okay. That's for high grade. She said etoposide and carboplatin. We usually use that for high grade neuroendocrine cancer. All right. Huh? Everolimus, also known as Afinitor. All right. Avastin, yes, we have that on clinical trial. Anything else? Huh? Captim. Captim is also known as Xeloda. Temodar is temozolomide. We usually use those in combination. Sutent. All right, sunitinib. Anything else? Yay, we got PRRT. All right. Missing a couple other things. What do y'all usually have first before you get any of the other medication treatments? Yay, that's a big one. All right, we're not going to be covering a whole lot of side effects on that because that's another 2-hour class in and of itself. We are going to hit a few highlights. What other radiation treatments do we have besides PRRT? All right, liver-directed therapies, okay. Can somebody name me some of the liver-directed therapies? All right, we have radiofrequency ablation. We have radioembolization. We have bland embolization. We've got chemoembolization. We've got microwave ablation. There's lots and lots of treatment options. Do you guys understand how we come to determine what exact treatments are the best for you? Okay. Here at Cedars, I know that most other facilities that treat populations of carcinoid NET patients have what they call a neuroendocrine team. Here at Cedars, we have a neuroendocrine team. What we do is we sit down every Monday morning and it's a group of doctors. There's usually about 10 to 15 of us in a room, and it's the oncologist, the radiation oncologist. We have the radiologists that do the procedures like the radioembolization and the radiofrequency ablation and all of that in there. We have the cardiologist. We have an endocrinologist. We have all kinds of physicians, everybody that takes care of our NET patients. It's all the doctors that we refer our Cedars patients to. A lot of times we have research, we have social work, Claudia in the background, who unfortunately is going to be leaving us soon, and we are very sad. Social work is there, nutrition, everybody, psychiatry, whoever we need to have in there is in there. What happens is we present the patient, usually the oncologist or the nurse practitioner, whoever wants to, the surgeon, all the surgeons are in there, they present the patient. We put the patient information up on a PowerPoint on the screen. We view the scans. We look at your lab work. We look at everything. The radiologist who's in the room actually reviews the scans again on the screen and does the remeasuring in front of everybody in the room. Then we start trading ideas. Here at Cedars, we like to have plan A, plan B, plan C, and hopefully plan D. Okay? What things that we try to take into consideration is not only what's the best treatment for right now, but if we treat you with plan A right now, what long-term side effects are you going to have 10, 15, 20 years down the road that may prevent you from getting some other type of treatment? We try to think about all of these things before we say, this is what we want you to do. That is what we want you to do. Sometimes, yes, we argue. We think this is the best treatment, or we think that's the best treatment. Pardon me, I need to take a sip of water. As we do that, there are different ways we rehash that argument. It may require more testing to make a definitive, should we go with plan A, should we go with plan B, or do we think at this very moment in time, based on you and your individual scans, labs, symptomology, overall state of health and things like that, where are we going to go with this? This is how we determine every patient is different. We could have 15 patients with pancreatic neuroendocrine cancer, and we are not necessarily going to treat every one of you the exact same way. Okay? So it's a team effort. It's not something that we're just going to go bam, 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 rubber stamp, you've got this, you've got a small bowel carcinoid, bam, this is what we're going to do. So it takes a lot of thought, and we do take a lot of time to consider. If you progress, if you have changes, if your symptoms are increasing or something like that, guess what? You get presented at tumor board again. And we say, do we stick with plan A and maybe tweak it here? Is it time to switch to plan B? What are we doing? Okay? So it's an ongoing process. Just because you've been presented once doesn't mean we're stuck on plan A, B, C, and D. And as new therapies and new treatments and new things come out, which is fabulous, sometimes we're trashing plans B, C, and D because now we've got all these wonderful new therapies and new treatments and new things available. So I just wanted to kind of give you all an overview of how we decide you're going to be on CAP-TIM, you're going to get PRRT, we're recommending radiofrequency ablation for you, and we want everolimus for you and things like that. It's not we're just drawing numbers out of a hat or matching you up or whatever. There's a whole lot of deep thought and deliberation that goes into what we pick for you, okay? Any questions so far right now? Yes, sir.
How often does a particular patient get his case presented before the tumor board?
Usually we present a patient when they first present to us. In other words, if they've already been diagnosed with neuroendocrine and they first come to Cedars, so it's the first time they present to us, if they're a brand new patient, and things like that. So they're coming in, no diagnosis, we're trying to work them up and figure out what's going on. If we suspect it's neuroendocrine, we'll present them, even if we don't know 100%, because we can get a lot of ideas from each other. It's wonderful the energy that goes on in there, because when the ideas start flying with the doctors and the nurses and all the supportive personnel in there, the energy in the room is phenomenal. And you've got all these wonderful minds working for you. How often they get presented? You get represented again. Usually the pattern we're falling into now, it used to be if you had a problem. If you progressed or something's going on or we needed to go to a different treatment or think about switching therapy options. Now what's happening is Dr. Hindafar, who's the lead oncologist here for the Neuroendocrine program, what he's doing now is usually after every scan. He'll pop you up back there again. We may only spend a minute and say, so-and-so scans, everything's stable. The radiologist just rechecks the measurements just to make sure that the radiologist that read the report, he verifies theirs. And things like that. And it's like, okay, they're good to go. Therapy's working. We don't need to change anything. We're good to go. But that keeps your name and all of our NET patients fresh in the tumor board's mind. So if we send you for a consult because you're having this symptom or this problem or that problem, they already know you. Or if they don't know you by face, as soon as they pull you up and start reading your information, they're going to go, oh yeah, we talked about her 2 weeks ago in tumor board. So did that answer your question? Fabulous. Okay.
So you know us by liver, not by face.
Yes. Dr. Nissen, one of our surgeons, one of our famous liver surgeons and works on pancreas, sometimes he's operated on some of our patients so much he can glance out of the corner of his eye and go, oh, that's so-and-so, and go right back without ever looking at the name. Because he's been in their inside so much that he knows exactly what they look like and where he has put things. And so we just laugh because he goes, oh, that's so-and-so, and goes back to whatever, and we're like, all right, go Dr. Nissen. That's just how it works. So any questions right now? Are we good? All right, so the first group, and usually the first type of therapy we tend to put you on are somatostatin analogs. The two big drugs in those right now are sandostatin LAR depot by our lovely friends from Novartis. All right, and then we have lanreotide from our lovely group of friends at Ipsen, okay? We are not going to be discussing, we don't have time today, mechanism of action and how these drugs work and things like that. We are hitting side effects, okay? If you're on these therapies, these are some of the side effects you can have, and this is what you're gonna do to take care of them, okay? If you want to know mechanism of action and all of that stuff, I'm going to refer you to some different places. There's resources listed at the end. You can always go to the Novartis website, the Ipsen website. You can Google Sandostatin LAR or lanreotide or whatever, and it's all going to pop up. You'll be able to find it. It's listed at the back, but for any actual drug name or drug that I discuss, the Cedars recommended website, it's also recommended for most any major comprehensive cancer center in the United States and Canada, is chemocare.com. I can't think of his name, Mark, the figure skater who had testicular cancer. No, it's not Lance Armstrong. Lance Armstrong was bicycle. But the figure skate, anyhow, he has dedicated his life to this website. It is updated as soon as a new treatment is on. It's updated. He has educators that make sure it's written at a specific grade level or below, so it's not too complicated for people to read. Anytime anything changes, he has people that scour the literature and do that. There's an expert review board that reviews all of this information. That's why just about any major comprehensive cancer center you're going to go to in the US and Canada where we are authorized to print off drug material for you is chemocare.com. Okay, that's the Cedars recommended site, and if I'm going to do chemo drug teaching on any of you guys, it's going to be printed off of chemocare.com. All right, that's listed at the back. On the very last couple of lines, there's 3 websites there. Those are the websites that we are allowed to refer patients to. I also give y'all, if you're a NET patient, I give you the list of NET resources, which you can also get off of LACNETS and other places, of where to go if you have questions, but 3 big cancer places of where to obtain good, safe, accurate, up-to-date information are cancer.gov and cancer.org, American Cancer Society, and the National Cancer Institute, and chemocare.com. All right? Somatostatin analogs, some of our wonderful, wonderful side effects from those. GI upset, and when we're talking about GI upset, we're talking about abdominal pain, nausea, vomiting, diarrhea. It actually can give some folks constipation. Injection site reactions, pain, redness, bruising, lumps. I hope you're not having any drainage from there. If it is, it means you got an infection and we got a problem. All right. You can get gallbladder issues such as gallbladder sludge and gallbladder stones. It can elevate your blood sugar. Okay. Pancreatic enzyme deficiency, if you've been on it a while. Decreased pancreatic enzymes is an expected side effect of being on somatostatin analogs. It's not unexpected, it's expected. Okay, so over time, the longer you're on this, some folks get it a month or 2 after being on it. It depends on what type of surgery you've had. How much of your gut is missing, whatever. Some folks a month or 2 on this will automatically need pancreatic enzymes. Some folks can be on it 5 years and then suddenly start developing the symptoms of pancreatic enzyme deficiency. Gas, bloating, greasy, oily looking stools, light colored stools, stools that float in the toilet. We're going to be talking a lot about poop today, people, so I hope nobody's squeamish, okay? Because unfortunately, if you've got carcinoid neuroendocrine cancer, it all centers around poop. All right? You can have some neurological side effects, headaches and dizziness. You can also have fatigue. First thing I'm doing on this is I'm running down the different therapies and major side effects. Then I'm going, because so many of them have the same types of side effects, then I'm going to go over how to manage each group of those side effects, okay? Your oral chemotherapy medications, such as your everolimus, which is also known as Afinitor, your capecitabine, also known as Xeloda, your temozolomide, also known as Timidar, your sunitinib, also known as Sutent. Those type of medications can affect a lot of things. How many of you guys know the mechanism of action for chemotherapy, what it actually does? Okay. The only difference between a normal cell in your body and a cancer cell in your body is a cancer cell is an abnormally fast-growing cell that doesn't listen to the signals the body sends it telling it, you can stop growing now. It's like an unruly teenager. It ignores everything and does what it wants to do when it wants to do it, okay? Unfortunately, a lot of the chemotherapy medications that we have available, whether it's intravenous chemotherapy like the carboplatin, cisplatin, etoposide that we give for high-grade neuroendocrine, or if it's some of the oral drugs that we give for the low-grade, moderate-grade carcinoid neuroendocrine tumors, affect fast-growing cells. The problem is a lot of that chemotherapy can't differentiate between the good, fast-growing cells, normal cells in your body, and the bad, fast-growing cancer cells. A lot of the newer therapies are getting much better at that. That's why we're calling them targeted therapies. But still, sometimes even those targeted therapies do affect some types of cells in the body. There are three main groups of cells in your body of normal, fast-growing cells that tend to be affected. We're very lucky in the carcinoid neuroendocrine population that a lot of those drugs, except for like I believe it's the Sutent and the IV chemotherapy drugs, don't affect your hair. Okay? Those are the ones, the hair follicles are fast-growing cells, believe it or not. Some of you may think, oh, it takes forever for my hair to grow out. Not according to the biology in your body, and you get some IV chemotherapy or some other types of chemotherapy drugs, especially like the drugs that our leukemics and our poor breast cancer patients have. And that hair's gone. It will come back, usually, unless you were like 99% bald before you started, and then there's like a 99.9% chance you're not going to get hair back after, okay? Although I've had patients tell me, Tina, he's got hair in places he's never had places before, and I'm like, that's more information than I ever wanted to hear. So we're not going to spend a lot of time on that because it's not a very common side effect for neuroendocrine. If you do have a question and you want more information on it, that's what these cards are for. Everybody can grab one, write your question, put your name and phone number on it, let me know, and I'll give you as much information as you can possibly stand, okay? A lot of the oral chemotherapy medications will cause abdominal pain. They can cause mouth sores, the lining of your gastrointestinal tract, from your mouth, your esophagus, through your stomach, your intestines, all the way down to your rectum. That's covered by this lovely, shiny, nice, smooth, slick, what we call a mucous membrane. That entire mucous membrane is fast-growing cells. Well, guess what? The chemotherapy can affect that, so that can give us nausea, vomiting, mouth sores, diarrhea. All right? Affects all of that. The third main group of cells that are affected by chemotherapy medications are the cells of your bloodstream and your bone marrow. So that's where your low red blood cells, your low white blood cells, and your low platelets come in. Okay? That's what people are like, y'all are always drawing blood every time I walk in the door. Why are y'all always sticking me? We're sticking you for safety. Okay, and I will get more into that when we're discussing the side effects. But number one, that's how we monitor your treatment. Number two, that's how we make sure you're safe. Okay, yes, we have to poke you, and yes, you think we're taking all your blood and you're going to need a blood transfusion. But we've got to monitor those counts to make sure that you're not getting into the danger level. Okay. Oral chemotherapy medicines also require chemotherapy precautions, and they require safe sex precautions. Yes, people, at the end of this, we are going to be talking about sex. Okay, so if anybody's too squeamish about that and you don't want to know, I will give you the 30-second warning, and y'all can go stand outside while we cover it. Okay? All right, any questions right now to this point? Okay. Am I boring anybody? All right. There are a few special side effects that are particular to certain drugs, oral chemotherapy drugs. The everolimus can sometimes cause upper respiratory infections or pneumonitis. So we will be monitoring those patients closely. That's why Hong and Dr. Hindefar are always listening to your lungs, and they may listen instead of just once, they may go back and listen twice. If you've got a cough or you're having a chronic cough or something like that, we're going to be sending you for chest x-ray just to make sure you're not brewing something in there, okay? Capecitabine can cause hand-foot syndrome. For those of you that don't know what that is, and I'm not covering that as in depth on this. If you're on the drug, I've given you information on it. If not, let me know and I'll be happy to go over it with you individually. Hand-foot syndrome is a redness and increased redness sensitivity to the palms of your hands and the soles of your feet. You can have some skin sloughing and skin changes and things like that. There are certain things that we do to take care of that. The sunitinib, like I mentioned previously just a few minutes ago, can also cause hair loss. Okay? For the PRRT therapy, biggest complaints we hear are abdominal pain, nausea and vomiting, decreased blood cell counts. You can occasionally get some hair loss and thinning. And it does require radiation therapy precautions. I am not going into radiation therapy precautions because they are very specific to the specific type of radiation therapy that you have. If it's PRRT or if it's radioembolization or whatever, if you're going to have that treatment, whoever is giving you that treatment in the discharge instructions, they are going to give you very specific instructions on what you need to do to manage that and the side effects to look out for. For your embolizations, abdominal pain. Are y'all noticing a trend here? Everything is abdominal pain. Everything's nausea and vomiting. Embolization there's also a risk of fever and infection. You can also have some blood clots. You can also have a lot of fatigue. Surgery. What's at the top of the list again? Abdominal pain. Nausea and vomiting, diarrhea or constipation, fever and infection, weight loss, bowel obstructions, adhesions, things like that. How are we going to manage some of these side effects? All right. Abdominal pain. Abdominal pain can be caused by a million different things. It can be caused by your disease process. It can be caused by your treatment. It can be caused because you're getting ready to start your menstrual period. It can be caused because you did too many sit-ups or on the rowing machine at the gym yesterday, or you pulled your back and now it's referring to the front because your stomach muscles are trying to compensate for your back when you were lifting the groceries out of the back of the car. All right? The way to treat abdominal pain is, number one, is we got to figure out the cause. Okay? The best thing y'all can do for any of the side effects that you are having is keep a symptom diary. All right, I know there's an app now where you can track all your symptoms. Is that going to do you any good if you can't pull that up and rattle it off to us when you're sitting there in the visit with Hong and I for your shot, or when you're in there with Dr. Hindefar? If you keep it on the app or in the notes section of your phone or whatever, make sure you know how to use it. Make sure you can pull it up, or before you get to the appointment, write it down on a piece of paper and bring it in. Okay? Please don't forget to bring it in. The more information you can give us, the better and the quicker we are able to help you. When we are assessing pain as your caregivers or your healthcare team, we are assessing things like date and time, We want to know when it happened. Are we noticing a trend? Because we're looking for trends. When we're asking for date and time, are you having abdominal pain every morning when you first get out of bed? Are you having abdominal pain every time you eat? Are you having abdominal pain at night before you go to bed? All of these different times of you having abdominal pain is telling us something different. That's why we are asking you to write down the date and the time. We need to know the severity. Yes, people, we want numbers. When we ask you to give us a number between 0 is no pain and you can do everything you absolutely want to do, and 10 is the worst pain you've ever had in your life and you can't do anything, we want a number. Unfortunately, the world is driven on data, all right? And we need to be able to quantify your pain, all right? With the fibromyalgia, I drive my healthcare team crazy because I rate different areas of pain differently. The neuropathy pain I can rate as something else, but the muscle pain I rate as something else. And they go bananas. They want one number. I don't care how you rate it. I just need numbers to work with. Because if you tell me that your pain is a 9 or a 10, between a 9 and a 10, I want to know what's your acceptable level of pain. What are you comfortable going through the day, or where would you like to see that pain be? I would think you would want your level of pain to be 1 or 2. But most patients are like, no, I'll be happy if I can get it down to a 5 or a 6. I can function. That's why we need the numbers. Okay, so you've got to quantify, please. Don't go, oh, I don't know, maybe it's this, whatever. Think about it, all right, and try to give us a number. 5 to 6 is medium pain. All right, 7 to 8 it's moderately high. 10 is like, you can't function. 0 is like, no, I'm great. 2 to 3 is like, I got some and it bothers me a little bit, but I'm moving and I'm doing okay. We got to have a number, all right? One of the other things we're assessing is the quality of the pain. We need adjectives or descriptive words. Is it burning? Is it sharp? Is it aching? Is it throbbing? Does it feel like somebody's digging an ice pick, or does it feel like somebody's playing tug of war with your intestines? Ever how you can describe it tells us something. Because believe it or not, in some of the medical books and the journals and things like that, if you've had 100 patients telling you that it feels like somebody's playing tug of war with my intestines, and then we find out this is what's going on, well, guess what? That's the first thing we're going to think of. You've got to give us information, okay? The more information you can give us, the quicker we can narrow it down, the faster we can help you. All right, so we need quality, we need duration. How long is it lasting? Is it coming and going? Is it lasting for hours? Is it only happening here or there? Or is it only happening with certain activities? What have you done to alleviate it? Did you take your medicines? Did you rest? Did you put a hot pack on it? Did you put a cold pack on it? Did you use distraction? Did you do yoga breathing? What'd you do? Did it help? Did it not help? What things are you finding aggravate it? Does movement aggravate it? Had a patient tell me last week, standing up and moving around hurts, but he's great driving in the car. And he had to get in the car and drive 3 or 4 hours to go to his granddaughter's wedding. He's like, no, I'll be fine. As long as I'm sitting and I'm driving, I'm good. He's like, when I get out of the car, now that's a different story. So we need to know what aggravates it. We need to know what alleviates it. Okay? You see where I'm going with all of this? Any questions so far? All right, so we can't help and treat your abdominal pain until you tell us what's going on. Some of the things you can do to help alleviate that are to let us know, take your medicines, and take your medicines as prescribed. I don't know how many patients come in and we have prescribed you, you've seen supportive care medicine, pain management, whoever. We've given you a long-acting pain medicine and we've given you a short-acting pain medicine. We spent hours talking to you about how to take those medicines and the purpose of them. You take the long-acting medication on a schedule to relieve your pain. You use the short-acting for any breakthrough pain that you're having. And then we're getting a call a week later and you're going, I'm completely out of my short-acting pain medicine. You're like, what do you mean you're completely out of your short-acting pain medication? We can't refill that prescription for a month because your insurance is not going to pay for it. And even if you wanted to pay for it out of your pocket, they're still not going to authorize you because federal law says you can have X amount of pain pills, blah, blah, blah. There's multitude of regulations and things like that. That's why we have you see the pain management specialist, and that's why we prescribe the medicines and try to teach you how to take them. The long-acting pain medicine works to keep your pain, it keeps the therapeutic levels of the pain medicine in your bloodstream, okay? So you're not doing this like you are with the short medication. You're reaching a peak, you got relief, you're crashing. You're reaching a peak, you got relief, you're crashing. The long-acting pain medicine gets you up and it keeps you steady so you're able to function. You're able to do your activities that you need to do. You're able to go to work. You're able to spend time with your grandkids. You're able to go to your granddaughter's wedding. You're able to come in here and see the doctor and tell us what's going on and do the things like that. There are a lot of issues I hear all the time. Well, I'm afraid I'm going to become addicted. People, you cannot get addicted if you have a legitimate need for pain. If there's a legitimate problem and there is pain going on, you cannot get addicted. You can become tolerant to pain medicine, and we may need to go up on your dose. But that's a different thing. That means you've become used to the medicine. And your body's like, okay, well, I'm going to jack up the pain, or it's going to take more medicine over time for me to do this. Cancer pain sucks. It sucks big time, okay? You've got to take your medicines appropriately, or what's the point, okay? If you've got questions, if you're not taking them right, or you don't think you've been taking them right, please talk to your healthcare team. Take your medications, know the signs and symptoms of when you are getting into trouble. And I've tried to highlight some of those. If you are at risk for small bowel obstruction, you need to know the signs and symptoms of small bowel obstruction. If you are at risk for blood clots, you need to know the signs and symptoms of a blood clot if whatever therapy or treatment you're on, if you're surgery or whatever. If you're at risk for cholecystitis, in other words, an inflamed gallbladder or gallbladder attack or pancreatitis, you need to know the signs and symptoms of that. Ask your healthcare team. You can look it up on any of those sites that I just referred you to, or you can Google it, okay? WebMD actually has really good explanations of things, basic explanations with basic signs and symptoms, okay? If you feel like you're getting into trouble, the best rule of thumb I can ever give you, if you ever get the niggling thought in the back of your head, like maybe I should go to the doctor, or maybe I should go to the hospital, your butt should already be in the car and you should already be heading there. You should not be thinking, and you wait a couple of hours, you should be in the car and going, okay? If it's something that's true for chest pain or anything else. If you're having chest pain and you're thinking, I need to go to the hospital, you don't ever get in the car or have someone else drive you, you call 911 right then. I'm also a CPR instructor for the American Heart Association. And so many people want to drive themselves to the emergency room, they ended up coding on the 405, okay? And the 101 or wherever, and then you end up causing a 10-car pileup because you were stupid and got in the car and had a heart attack when you should have called 911. All right, that's my thing on that, and we'll get off that soapbox right now. I'm sorry. Next, we're going to move on to the mouth sores. Remember, chemotherapy, some of the PRRT, a lot of different medicines can affect that mucous membrane. You will know it when you start to develop mouth sores. As soon as you eat something citrusy, as soon as you eat something spicy, as soon as you start digging into those nachos or those potato chips that start cutting or scraping in there, you're going to go yowza, and that's going to be the end of that. One of the things you can do is stay well hydrated. You can get a dry mouth will precipitate you to getting mouth sores if that's one of the potential side effects of whatever treatment you're on. You're going to see hydrate, hydrate, hydrate with an exclamation point after it, pretty much in everything in here, okay? I can't emphasize the importance of hydration enough. And when we're talking hydration, we're talking a minimum of 64 ounces of good fluids. Good fluids are water, low-calorie sports drinks, unless we're needing to increase your calories because you're losing weight and you've got no butt for me to poke to give you your shots. All right, and I'm telling you, you need to up the calories and you need to be drinking the full-calorie sports drinks. All right, herbal teas, diluted fruit juices, things like that. Bad beverages, or anything with caffeine, anything with carbonation, and anything with bubbles. Alcohol. I'm not saying you can't have your half a glass of wine or your glass of wine, you know, with dinner, or your beer before the Rams, or in my case, the Panthers game. I'm not saying that you can't have your cup of coffee in the morning. I'm not saying that you can't have your soda with your lunch and things like that at work. But guess what? That means you have to chase it with an extra, at least one extra 8 ounces of the good fluid. That doesn't count in your 64 ounces of the good fluid that you've got to have anyway, okay? You got to chase it. So if you've got bad in one hand, you better have a good in the other. All right, are we clear on that? Okay. You need to keep your mouth moist. Remember, if it's dry, the drier it is, the more likely you are to get the mouth sores. Suck on ice chips, sugar-free gum, hard candy. One of the things, and I always try to remind anytime I'm speaking to any NET group, is sugar-free gum, hard candy, all of that's great except the day of your scans and you're getting your labs done. Okay? You can have as much plain water as you want before you come in. You have to be fasting for like the MRI, the abdomen, or whatever, if you're getting the contrast and things like that for 4 hours. But the night before and things like that, you can have as much plain water as you want. No carbonation, no flavors, none of that business. Do not chew sugar gum, sugar-free hard candy, no sneaking green tea, black coffee, none of that crap to keep your mouth moist. Anything other than plain water stimulates gastric enzymes. Well, people, what do you think your tumor markers are? Gastric enzymes. Okay? So you're automatically giving yourself false positives anytime you put that mess in your mouth before you get your labs done. All right? So, yes?
What about coconut water?
No! Coconut water to hydrate, yes, is fine. Before your labs or your scans, no.
No, but just normal.
Normal is fine, okay? Not before labs or scans, plain water only. I can preach this till I'm blue and y'all still come in and your level's been like, you know, 200, 200, 200, 207, 207, and suddenly we got 1,000. And we're like, what the heck? And they're like, oh, my mouth was dry. I was chewing sugar-free gum. And you're like, Well, guess what? Fast again for 8 hours, plain water only, come in and let's repeat it. All right, y'all are having a heart attack because, I'm progressing. No, you're not. You chewed gum. Okay? So don't be an idiot, plain water only. Okay?
I thought they said you couldn't even drink water before MRIs and stuff.
Like 4 hours. But we want you hydrated before.
For the MRIs too, or just the...
Before you come in. So like the night before, you can have water. Stop drinking plain water 4 hours before you have the MRI. Okay? Clear liquids, everything's, no food, none of that. Anything else but plain water is fine. All right, nausea and vomiting. Best way to manage that is to stop it before it starts. Okay? Nausea medicine, like pain medicine, should be taken at the first hint of nausea, just like pain medicines should be taken at the first hint of pain. You do not chase nausea, you do not chase pain. The medicines don't work as well, they don't last as long if you're trying to catch it. Then it does as if, maybe I should take my medicine. You need to be heading over there and taking it right now. Okay? If you're not sure exactly how to take them, let us know. All right? A very common medication we order for everybody is ondansetron, also known as Zofran. Okay, that one can only be taken, it's usually 8 milligrams 3 times a day. So if you're having continual nausea and things like that, we recommend that you take it on a particular schedule. Our CAP-TIM folks, we're usually recommending that you take it 30 minutes before you take your morning and your nighttime dose of the capecitabine. Okay? There's just particular things that you need to do. If you're on the capecitabine, whoever was teaching you, and if it was me, I know darn well I taught you, you must take capecitabine with a full meal. Crackers, half a piece of bread, whatever, ain't cutting it. If you take capecitabine on that minimal amount of food, you are 100% guaranteed to chuck. All right? We're talking about a protein and a carb, full meal, breakfast, dinner. Take your anti-nausea medicine, eat a full meal, take your capecitabine. All right? People who usually say, oh, I'll be fine with 2 peanut butter crackers, or oh, I'll be fine with a piece of bread or a plain toast or whatever, regret that statement and they never repeat that mistake again as soon as they do. Because from what I understand from folks that have made that mistake, they're like, I never want to do that again. That was the worst emesis I've ever had. All right, so let's not go there. That falls under plan your meal times based on the type of therapy that you're having. Some chemotherapies recommend that you eat beforehand, like the capecitabine. Others recommend, especially our IV chemotherapy folks, sometimes that you just eat lightly. What I do recommend is that if you're having nausea during your treatment, that you don't eat your favorite foods during treatment. A lot of times what will happen is after you're completely done with your chemotherapy or your treatment, that favorite food you never want to eat or see again. Okay? Just because you are going to associate it with the treatment and the cancer and everything else, and you're like, dear God, I never want to see it again. All right, so another way is eat bland foods, not heavily spiced, not greasy, fatty. A big thing that will set a lot of people off are odors. Hot food has an odor. It's steaming. Cooked food, if you think about it, has an odor. As soon as, like if you're in the hospital, you lift that lid, the steam hits you in the face. If you're standing over the stove cooking, whatever, that steaming is making you nauseous, okay? If you're getting nauseous when you're cooking, this is your excuse to give up on cooking while you're on therapy. All right, I'm gonna have spouses and caregivers like throwing things and sending me hate mail now, stalking me on Facebook. But cold foods, bland foods, room temperature foods, if you're going to have a cooked meal, let it sit down, let the steam dissipate before you start to eat, okay? Just let it cool down just a tad so the steam's not hitting you in the face. Avoid strong odors, perfume, hairspray, cigarette smoke. If any of your caregivers here at Cedars are wearing perfume or some odor that offends you, you need to let us know immediately. Cedars' policy here is we are not allowed to wear any strong odors and things like that. I don't wear any scented body lotion or any perfume when I take care of patients, okay? I don't want to ever trigger you guys. We have had some people here that have worn it. I get migraines easily. It's part of one of the fibromyalgia syndromes, and immediately if somebody's got really heavy perfume on, gives me a migraine, and it's like, where's the garbage can? Because I'm like, bleh. It can trigger it that fast, and it's miserable for me, so I know it's miserable for y'all. Please, please, please let us know or make your nurse or doctor aware if it's somebody else, and we will speak to them because it's policy and they are not allowed to do that, all right? Breathe deeply. The vomiting center in the brain is also your visual center. Keep your eyes open if you are feeling nausea, because vision takes precedence over nausea. Find a point, fixate on it, do your deep breathing. Okay, the minute you shut your eyes, the nausea overwhelms you and the feeling just gets worse and you're going to choke. Okay, cool cloth, cold cloth, the colder it is, the better. Back of your neck, your forehead, keep your eyes open and do your deep breathing. All right? If you are having more than 4 to 6 episodes of nausea or vomiting within a 24-hour period after you've taken your anti-nausea medicines and they are not controlling it, you're not able to keep fluids down, you need to notify your healthcare team. We need to get you in, we need to draw a chemistry panel on you, make sure you're not getting dehydrated, we need to give you some IV fluids, okay? If this is happening and you're feeling really, really bad like that, go ahead and pack a little overnight bag, because we may just have you in the ER overnight in observation getting a couple bags of IV fluid. If it's during the day, we may, if there's room, we'll shove you in the infusion center over here, which is open 24/7, 365. We'll shove you over there, give you a bag of IV fluid, and send you home, okay? Hydration is very important. If you are not hydrated enough, all of your organs, brain, heart, lungs, kidneys, everything else can shut down. All right, so don't give us lip when we tell you, if you're telling us you're having this, and we tell you, you need to get here and you need to get here now, or you need to go to the closest emergency room if you live in San Diego, or whatever, you need to call your local oncologist and you need to get in there, you need to go to the closest emergency room. All right, we're not telling you just to tell you to cover our behind, we're telling you because there's a problem and there are consequences. Any questions? All right. Diarrhea. Keep a symptom diary. All right. Diarrhea at different times or for different reasons tells us different things. Is it medication related? Is it disease process related? Is it particular food items that you're eating that are triggering carcinoid syndrome, diarrhea? What's going on? More we know, the better we can help you. Be descriptive. I prefer if you don't send me pictures of poop. Although there are days I walk in and open up my email, hey Tina, I got a problem, there's an attachment, I open it up and there's a picture of the toilet and poo. At least it's not, I'm not the surgical nurse, thank God, and I'm getting wounds with drainage and things like that because I don't do wounds. All right, poop, I can stand, emesis, I can stand, I don't do poop, I don't do wounds. All right, so if you absolutely have to, okay, but try not to make it just every now and then and not every day. All right, take all your anti-diarrhea medicines as instructed. Let us know, okay? Depending on what the cause of the diarrhea is, we may tell you to take anti-diarrhea medicines, we may tell you absolutely not. We may require a stool sample, okay? If it's, anybody ever heard of C. difficile toxin or had C. difficile toxin diarrhea? Okay, it's nasty. It's an organism that you can get called C. difficile. It gives you like yellowish greenish diarrhea and it has this very peculiar foul smell. Once a nurse smells it, you will know 100% if you ever smell it again, as soon as you walk in the door, they got C. diff. Whether the sign, they've been tested for it, the signs are up or whatever, every nurse you smell it one time, you automatically know they got C. diff. I don't care what anybody says or whether the test results are back yet or not, you know. C. difficile and some other types of organism-related diarrhea have to be treated with antibiotics, and you don't want to take anything to stop the diarrhea. It has to pass through the system. Okay, that's why we require a stool sample sometimes. And I don't mean you did the stool sample 2 days ago and then you mosey on up here. If we have to, we will scan or fax you a script, or we'll scan it and email it to you, and you can go to your local Quest or your local LabCorp. They'll give you a cup and you can poop in it, and then you can take it to them fresh. and they will check it for VRE or C. diff or whatever toxin or thing that we need to check, okay? You will get to know your diarrhea. You will get to know if it's carcinoid-related diarrhea, if it's diarrhea after your surgery as your gastrointestinal system is learning to readjust because you've had pieces removed and reattached here or there and things like that. You will know if it's food-related. As time goes on, you will learn to know if it's medication-related. Trust your gut. If your gut is telling you something ain't right and maybe I should need to go get this checked out, what are y'all gonna do? All right, get in the car and go get it checked out, right? Okay, I'm not hearing a whole lot of yeses. Yes, Tina. Yes. All right, that's when I say something like that, I expect yes, Tina. Okay. That means everybody's awake, you're listening, and you know what to do. There's a thing called a BRAT diet, B-R-A-T, bananas, rice, applesauce, and toast. A lot of you who have had children have probably heard this from the pediatrician. It's a good thing to use. If you're having nausea, vomiting, you're having diarrhea, you've got the flu, or just things don't feel right, and we tell you, drink a lot of fluids, eat a bland diet, whatever, until things settle down. Pedialyte is a good thing. Yes, it's for children, but guess what? It also works for adults too. When we're saying bananas, rice, applesauce, and toast, I'm not talking about rice with salt and gravy or butter and sugar like we Southerners love to eat it. I'm not talking about toast with butter and jam. Applesauce with cinnamon and chunks of apple homemade on the stove or whatever. I'm talking about the Little Mott's applesauce or the baby food applesauce. No spices, none of that. The very easily digestible, your system doesn't have to struggle, plain dry toast, a plain banana, plain white rice. Okay? Not this lovely mix of wild grain and long rice and brown rice and all of that, because that's a lot of fiber and it's going to tear your stomach up and make the diarrhea worse. All right, that's your BRAT diet. If your bottom's getting raw and sore, use baby wipes instead of toilet tissue. You want to pat instead of rub, okay, or rub really hard. I'm hoping everyone, especially for females, you learn this as a child, but surprisingly, we get a lot of folks with urinary tract infections. Women, you need to wipe front to back. Always front to back, so you don't end up with a vaginal infection, a urinary tract infection, or whatever, okay? For men that aren't aware of that, for women, and you've got daughters or small children at home that you're trying to potty train or whatever, y'all need to know this so you can teach your little girls or whatever that if you see them doing it wrong, honey, you need to learn to wipe front to back, all right? I love the dollar store. Dollar store is great for NET patients because you can get your salt and your soda for your salt and soda mouth. Oh, I forgot that under mouth sores. All right, we're putting the brakes on. We're backing up to mouth sores. Salt and soda mouth rinse, especially if you're on everolimus, also known as a Afinitor. It's a fourth a teaspoon salt and a half a teaspoon of baking soda in like 8 ounces of warm water. You can mix up fresh every day. You need to swish and gargle or swish and spit a minimum of 4 times a day. I highly recommend before and after you eat, before you go to bed. If you get up in the middle of the night to go pee, you need to be swishing while you're sitting on the potty peeing or standing doing your business, whatever. Okay? Number one way to help prevent mouth sores, especially if you're on Afinitor. If you know you're going to be starting Afinitor and we're waiting on the authorization and we're waiting on the mail order pharmacy to send you the drug, I want you to start the mouthwashes then. I can tell if you've been doing your mouthwashes because when you walk in the room and I'm like, open your mouth and let me see, you're going to be busted if you haven't been doing it. It should be nice and smooth. They may be pale, but they should be nice and smooth and shiny and moist. If they're not, I'm going to know you haven't been hydrating and you haven't been doing your mouth rinses. Folks that have done their mouth rinses, if you do get a mouth sore, They're very minimal. They don't last near as long. They heal very quickly, and you have much, much less pain than the folks that wait. We have had, especially our poor folks like our leukemics and our breast cancer patients that are on high-dose chemotherapy drugs, end up in the hospital with infections and on pain pumps. Mouth sores can be that bad to where they can't eat, they can't drink, they can't do anything. I've seen some really, really bad mouth sores from everolimus. And it's because they got taught somewhere else or started the drug somewhere else and came to us, and they weren't taught to use their mouth rinses. So if you are here, you get taught to use those mouth rinses. Back to the dollar store. You can buy, for $1, one of those big containers of Morton salt. You can buy one of those big containers of Arm & Hammer baking soda. You can buy one of those jars with a lid, or one of these that you can mix your salt and soda up in for the day, and you can keep it in the bathroom so you can swish and spit. All right? Also, while you're at the dollar store, you know those lovely mustard and ketchup squirt bottles and things? They make great, great, great little bottles to hose yourself off with warm water if you are having diarrhea. Okay? To keep yourself clean. Pat with your baby wipes, hose yourself off with that, and then pat very, very gently with the toilet paper just to dry. And don't rub. There's also a fancy thing that you can spend tons and tons and tons of money on at CVS, Rite Aid, Horton, Converse, whatever, called a sitz bath. It's this fancy device that you put water in and sit in the toilet and plop your naked behind in. Or you can stick your naked butt in 2 or 3 inches of warm water in your bathtub. Clean bathtub, and this is not a Calgon moment, people. All right, no Avon bath bubbles, no Calgon, no this fancy stuff that you bought at the spa up in Northern California or whatever. It's plain warm water. No soap, no bubbles, no nothing. 5 to 10 minutes, a couple times a day will help your bottom heal, okay? Especially if it's sore and tender from the amounts of diarrhea you're having. If it's getting really bad, guess what? There's this lovely stuff called Desitin or diaper ointment. Yes, it's for babies, but it works fabulous for your bum too. It's for all ages. All right, you can get that at the dollar store. All right. Any questions about the diarrhea right now? If you have more than 4 to 6 episodes of diarrhea above your baseline, and that's the important part, above your baseline. If you usually have 4 episodes of diarrhea a day, in other words, loose stools, soft stools, whatever, and that's your normal, but suddenly if you're having 4 and now you're having 8 to 10 in one day, you need to let us know, because that's a change. If we can attribute it to something, great, but if you're having it and you don't know why, you need to let us know so we can figure out what's going on.
What was you said,
Desitin or whatever, the baby ointment. Go look in a little baby aisle. They got all the baby crap lined up. There's that hydrate again. All right, I'm not going to discuss hydration again because we've already talked about bad and good. Take your fiber supplements and stool softeners as directed. If you are on pain medication, you need to be on a fiber supplement and a stool softener in addition to all of your hydration. Moderate daily activity. I know some of you guys, fatigue is your biggest complaint. Even if you're not doing anything, if you can just get up and walk to the mailbox and back, or around the house a couple of times. Whatever, you need to try to increase your activity, or at least do a little bit of moderate activity, moving, walking every day. That's going to help.
Things along.
Thank you. Gravity, peristalsis, the natural movement of your GI tract. It's going to help things move along. All right, the big one, pancreatic enzyme deficiency. How we know that's happening, you're having the abdominal pain and cramping after eating, bloating and flatus, fancy medical name, i.e. gas. You're having a feeling of fullness or a feeling that the food is just not going down. A lot of folks tell me, whether they're male or female, I feel like I'm 9 months pregnant. About 30, 45 minutes after they eat. Feel like the food's just sitting right there. Have diarrhea or dumping syndrome immediately after eating, or you're having the greasy, oily, light-colored stools that float. The way we're going to manage that is people take your Creon and take it right. Okay, I know a lot of you are wanting to try the natural way, and you're on all of these expensive supplements that you're buying at the health food store, or you're buying the Digest Gold at Costco or wherever. That's fine and dandy if it's working for you, but guess what? Creon's natural too. It's a combination of pancreatic enzymes, but it's a higher strength. If you're still having these symptoms on all of that expensive stuff that you're spending your money on, guess what? It's not working. Quit spending your money on it and get your script for Creon. If your insurance won't pay for it, and we do run into that, let your healthcare team know there are ways we can work it. We can try what's on their formulary first. A lot of times they will want you to use the Zenpep or something else. A lot of times the Zenpep will work. If the Zenpep doesn't work, we document it. We document in the medical record that you've been on X, Y, and Z, that you've been buying over the counter. You were on them for so long, you're still having these symptoms, things are getting worse. We put you on the formulary that they recommended, the Zenpep, you've been on it, now you're having all these signs and symptoms, still not helping, you're still having the pancreatic enzyme deficiency. Then we fight and get a prior auth, we can get an override, we can get the Creon covered. Okay, standard ordering dose here at Cedars for Creon is we order it, it's ordered by the amount of lipase, so it's 24,000 units, 2 capsules before meals and 1 capsule with snacks. That's not written in stone. If you are going to Roscoe's Chicken and Waffles for brunch, and you're having the chicken special and you're having the waffles and you're like, oh my God, I gotta have their mac and cheese. Can y'all tell where I had dinner Saturday night with my boyfriend in Pasadena? And I'm looking at these folks over here. Yeah, but I had the mac and cheese. I love it. And you have pancreatic enzyme deficiency people, 2 Creon ain't gonna cut it. For something like that, you're gonna need 4 or 5 Creon. I'm not kidding. If you're having a regular dinner of like baked chicken and broccoli and some rice or something like that, 2 Creon are fine. If you're pigging out at Roscoe's or it's the 4th of July and you're having the backyard barbecue, you're having hamburgers, ribs, hot dogs, and the whole works, you're gonna need 4 or 5 Creon, all right? If you need more Creon to cover you for the month, or you find you're needing more, or you know you're gonna be bad, pre-medicate, okay? I don't care what the instructions say or what you read on WebMD or the PDR or what the pharmacist at Walgreens, Walmart, Rite Aid, or CVS tells you. The way to take your Creon is your food is sitting in front of you. The Creon's in your hand. You take your Creon, you take your first bite of food. You do not take this crap 30 minutes before you start to eat. Creon hits your tummy, it's all dissolved with the stomach acid there, and you got nothing left when you start eating. Dr. Medizaday, who is the GI specialist that sees a lot of our NET patients who we can't manage on our own for this, has stood up in front of this and at NET conferences and said, I don't care what they say, this is how you take the Creon. You ignore whatever else they tell you. Food's in front of you, pop your Creon, eat your food. First bite, before the first bite. Yes, sir.
How common is pancreatic enzyme deficiency with somatostatin analogs like sandostatin? Because I don't think I've ever had those symptoms, but
On just the short-acting sandostatin,
the long-acting.
you do have it. Not all folks get it. Some folks do, some folks don't. And don't ask me the mechanism of action, I don't know. Novartis reps are sitting back there, and they may be able to give you a little information or can point you to where on the website. We just know that it's something that can happen that over time, a lot of our folks end up, it decreases the amount of the natural production of the pancreatic enzymes in the body. Some folks, we've got patients that have been on sandostatin 20 years. Never have a problem, not on creon, not on any type of pancreatic enzyme. Other of our patients, 1 month, and they're coming back and their first LAR shot. They're coming back and they're already complaining of this. And so Hong or Dr. Hennefar, whoever is like creon, or I'm running to them if it's just me seeing, I'm like, we need a creon script, and they're writing it out and we're giving it to you, okay? Everything else you need is on here, low blood cell counts. One thing I do want to cover that's of utmost importance of the low blood cell counts, anytime y'all have a temperature greater than 100.4 Fahrenheit or 38 degrees Celsius, this is what, if you're a patient and you've had like PRRT or you're on oral chemotherapy, any type of treatment that can decrease your blood cell counts, if you are running a fever, that is what we in the healthcare field call an oncologic emergency. It's a true emergency. This does not mean you take 2 Tylenol because it's 3 o'clock in the morning, you roll over in bed and you go back to sleep. People, y'all could be dead in 2 hours. There's this lovely thing called sepsis. If the bacteria or whatever is virulent enough in your bloodstream, it gets in your bloodstream, it can go to your heart, your brain, your lungs, your kidneys. It can shut everything down. I'm going to give y'all an example. When I worked at Northwestern, we had a bone marrow transplant patient. 22 years old, had a wife 20 years old, they had 2 small children. He had been instructed 100 times, if you run the slightest amount of fever, you need to come in immediately. He lived 2 blocks from Northwestern. His wife called, he was fine at noon, she checked on him at noon. She got home at 4 o'clock in the afternoon, he was dead. 22 years old with 2 kids. When they did the autopsy and checked him, he had been running a fever. All right, I can't emphasize the importance of this. You go to the closest emergency room. If you live in San Diego, you don't get in the car and haul your behind all the way to Cedars. If you live in Joshua Tree, you go to Joshua Tree Hospital. You don't haul your butt all the way to Cedars or whatever. You go to your closest emergency room. You tell them, I'm a cancer patient. I'm on treatment that can decrease my blood cell counts. So they know that. And I am running a fever. That's basic cancer medicine. Any emergency room or urgent care in the United States, if you tell them those 3 things, they are going to know this. They're going to do several things. They're going to get vital signs on you. They're going to draw a lot of blood. They're going to draw blood twice. They're going to draw, if you've got a central line like a portacath passport or something, they're going to draw blood out of one of your arms, and then they're going to draw blood out of your central line. If you don't have a central line, they're going to draw blood out of one arm, and 10 or 15 minutes later, they're going to draw blood out of the second arm. The amount of bacteria in the bloodstream, infection in the bloodstream, can change in 10 to 15 minutes. If you've got a line, that tells us, is it a bloodstream infection or is it just your line that's infected? So we have like one and we have the control. It's going to be 2 sets either way, so don't give them lip when they come back 10, 15 minutes later and draw that second set. If you're coughing, you're going to cough in a cup and spit. You're going to pee in a cup, you're going to poo in a cup. They're going to do a chest x-ray to make sure you're not brewing a pneumonia. There's going to be people in checking you out from head to toe. They're going to start an IV on you, and they're going to start IV fluids, and they are going to start 3 or 4 broad spectrum IV antibiotics. They are going to be hitting you with all of this and get it going on you as fast as possible. You are going to take precedence in the emergency room unless somebody is coming in with a heart attack or you see people coming in on stretchers and there's blood everywhere. Otherwise, you are in an oncologic emergency. They know this and you are going to take precedence in the emergency room. Okay? Do not take your Tylenol and roll over and go back to bed. I don't care how bad you feel. Yes, I know you're going to feel crappy, but this is a life-threatening emergency. Get your butt up. Get somebody to take you. If you have to call 911, you call 911.
I have a general question related to the abdominal pain and that sort of thing that can happen with all these treatments. What about gurgling? Like if you have, like right after you eat, you start to gurgle. What does that mean?
It can mean a lot of different things. It depends on it. If you've just had surgery, gurgling bowel sounds are good. It means things are active. We don't want hyperactive bowel sounds. In other words, a whole lot of gurgling. If you sit there, if you listen with the stethoscope, or if you put your ear on your loved one that has a normal digestive system, and you listened, every few minutes you should hear in all four quadrants, if we divided the abdomen and across, you should hear different tinkling like gurgles and tinkles and all these different little sounds. You should hear something like maybe every 30, 40 seconds, whatever, in these different areas. If you're hearing a whole lot of gurgling and things like that, it could mean you've just eaten and it's trying to digest some food. If it's in the stomach area, hopefully that things are working. If you're having diarrhea immediately after, it means like you've got dumping syndrome. If you're having a lot of gurgling and then like 10 minutes after you eat, you're running to the bathroom and everything's coming out and you can tell it's not digested. You know, you're still seeing, you know, there's corn on the cob and oh, there's whatever. Sorry, but you're still seeing that and things. That's telling me we've got to slow that down some way. There are medications that we can give you for that, or it's telling me you don't have enough digestive enzymes in there. It may be related to your surgery, whatever. There's a lot of different things. We've got to figure out what's going on. So tell your healthcare team, keep that symptom diary. When's it happening? When are you hearing this gurgling? Is it right after you eat? If it's right after you eat, how often are you immediately going to poo, or are you having your normal bowel movements, or what's going on? Yes?
What was the app that you were talking about for symptoms? Do you know the name of it? Oh.
She was asking, there's a Carcinoid app for tracking symptoms. I think there's a couple. Does anybody remember that? I don't remember it off the top of my head. Yes.
Carcinoid NET app.
That's it.
Say it, I'm sorry.
Carcinoid NET app.
Net app? Okay, thank you.
Through an Android and iPhone.
Okay.
All right. I'm sorry we didn't get to go through everything else, but it's all here. There's a great book at the National Cancer Institute, NCI, www.cancer.gov. It's listed there. It's it's the side effect. It's a whole thing. If you look under managing your side effects, there's a whole guide. Most of the information is taken from there. I've tweaked it for NETs. Every side effect under the sun for cancer patients is in that guide. So everything and more is on there. I just hit some of the highlights. All right?
Great job.
All right. I'm sorry I ran y'all over, but thank you. Thank you everybody for coming.